Good morning, everyone. It's a privilege to be here, and I appreciate the invitation from Jacques Morcos. And of course, I'm always very privileged to speak in front of Professor Sami. And I'm going to give you today not a clinical lecture, but a few thoughts about the challenges as a neurosurgeon practicing what Gail has told us and what we've seen in North Africa, and being part of this global movement challenges our personal ethics, our morality, and our style of practice each time. And I have some photographs. I'd like to take photographs. So this is the bridge I crossed to go to my house in Louisiana over the lake. And my surgical thinking is kind of like this. It's very linear, it's very precise. I know exactly the destination. I have a plan before I go to the operating room. But when you're in a new country, in a new operating theater, the road looks more like this. You have an idea at the end of the tunnel. You know you have to take out a thalamic tumor, but it's sometimes a dark forest, and you don't know who and what lives in it because it's not your home environment. Here are some things to consider. When you end up, as I do sometimes, in Vietnam or in Egypt or in Tanzania or in Nigeria, you see a patient in consultation in a new culture who you've never met before. Who owns the patient? Is it your patient? Or is it the patient of the colleague or the translator or the junior doctor who maybe has 2 years experience in neurosurgery is introducing you to this person? And are you doing the doing or are you teaching? Are you letting an inexperienced guy do a complex case to be a good teacher? You cannot teach him in 1 day how to do this thalamic tumor. Or do you do it yourself and then you miss perhaps the opportunity to pass on the craft? And what is the role of altruism? Because I come from a good economy, from the United States, and I feel like I should go and donate my surgical services. But is it good if patients are not financially obligated? If they have no skin in the game, we call it, will they take their medication, their antibiotics? Will they, in some countries, they buy their own hardware or their own hemovac drain and come to the hospital with it? And if I donate my time, do you know that hospital is not charging the patient for your fee? You are not aware of it? Sometimes, if you give your fee up and you say, I want it given to the family, and you go back 3 months later, 1 year later to the country, and I meet the family, they never received it. So because of the tremendous socioeconomic pressures, in a sympathetic way, we have to be a little German with our partners and very clear in the beginning what part is altruism from us and what the expectations are, to what extent we're supporting the patient versus the system. Another thing for me, I am a Romanian guy raised in America and Japan and England and New Zealand and everywhere. I feel as a global citizen, I could speak to anyone, and I made friends with many of you on the bus. But when you get informed consent, it's not just about translation, it's about health literacy. Does your patient know the Bedouin from the desert? Does he know what you're consenting to in that clinic when there is a long line of people waiting, time is running out, and they sign a form? So I have some reservations about how well that is done. And then there are cultural differences. How many times can you apply the vast scale to a Latin woman who says, what is your pain level? I'm already dead, doctor. I died last week. You cannot save me. Another stoic guy, I make rounds post-op in Japan. The patient says, I apologize, I didn't get better faster. I'm so sorry. I have no idea how they're doing. So if you do the Oswestry Disability Index score across every culture, it really is not the same, I believe, in Rabat or in Abu Dhabi or in Louisiana. And there's always this problem with complications. As a resident, I would take care of Dr. Vinko Doling's patients in Virginia. He would come, usually in a white suit like this, come from Europe. We're all waiting to see the cavernous sinus dissection. He'd make a beautiful surgery. Sometimes we would ask, I want to see the facial nerve. Oh, really? Okay, let me drill more. Then you can see it. It's right here. But then when he left, and there was a CSF leak, there was a problem, there was a deficit I have to make. I'm a junior resident. I am making rounds and explanations to the family what the great master did. Why is it not healing faster? And so in my mind, I have this worry when I leave a place, who's managing the complications? In my center, they come back to my ER. I take ownership. I readmit them. I take care of the family. But if they're somewhere else, it feels like you leave in a somewhat maybe irresponsible way. And then, of course, there's always the worry of the postoperative care in the ICU, the blood pressure management, those things, and the long-term follow-up. So these are both my opening statements and my conclusions. I think they're important considerations. So if it's so difficult, why should we still do it? Why do we try this global neurosurgery? And it's because we swear by Apollo, the physician, and Asclepius, the surgeon. Iatros in Greek, right, is healer. We are the healers. We swear in the Hippocratic Oath several things: to be good, to be righteous, to do the sacred act. But we also swear to teach, to hold a teacher as dear to me as my parents, and to look upon his offsprings as equal to my own siblings, to teach the art. So this is all of our obligation. This is why neurosurgery is like a genealogical association. This is why Dr. Jain and Dr. Sami are like my father, my uncle. And so, of course, the answer has to always be yes. We promise to. I myself, as a 19-year-old, grew up in Nepal in a very primitive operating theater, and in Hokkaido in Japan doing skull-based dissections on cadavers in the night. Free help, free mentorship, free teaching from everyone encountered. But when I was with Dr. Sami, if you ask ChatGPT, what are the principles of philosophy of Majid Sami? This is the ChatGPT response on top, okay? 6 of them: precision and perfection, education and mentorship, patient-centered care, holistic approach, innovation, and global collaboration. So operating abroad is very good for the ones in green: education and mentorship and global collaboration. For precision and perfection, I would like to hypothesize that operating outside of your home hospital is not great. The holistic, the innovation, it's different from country to country. This is me in Cairo, okay, in my clinic. It's 10 o'clock at night. This guy with the turban has been to the clinic 3 times since 1 a.m. Since he was waiting since 1 in the afternoon. He missed his films. He went and got a new MRI. He came back. I said, my clinic is full. He said, no, doctor. He has been waiting. He's from the desert. He rode a donkey and a buggy and a horse to get here. You have to see him. Okay, at 11 p.m., we are seeing patient number 90. I'm getting my 17th Turkish coffee. It's still time to work. At 1 a.m., we finish clinic. The residents want to go to have dinner. 2 a.m. is great to have a big lamb meal in Cairo. At 8, we have to operate. So Dr. Yashargil used to, count his peanuts and almonds before surgery. He said, it's like a sport. I have to take just the exact amount, So can you perform the same outside of your home environment with a different schedule, with a different stress, seeing 120 patients a day? Some of you may say that we are spoiled, okay? And I agree, maybe we're spoiled. This is my operating theater, and these are my crutches. My crutches because I like to be very organized. I don't like to bend my neck. I use the exoscope. I like the Mizuho table because it folds all the way to the ground. I like a port if I'm doing a deep tumor. They are, of course, crutches. It doesn't mean I forgot how to operate, but I rely on so much other technology that is not available where I go. I presented in the FAANS meeting in Romania in front of Dr. Sami in 2017 or 18. I said, I never do a tumor without tractography. You refer a tumor to me, I will do the segmentation. I will do it before and after. I will show the white matter recovery there at the top after my operation. I will take out that foramen magnum meningioma and measure the tract recovery. This hematoma, I will spare the coracospinal tract. All of these things that are part of my everyday, I cannot mimic or replicate in another country. I used to fight with Dr. Fukushima doing cases about these crazy Surgicel he has. You see how many they're cut in every single size? You know, all of us, all of you have some habit like this, where you are so, you would not be a superb neurosurgeon if you were not so precise, okay? So if you go to an environment where you don't have these things, are you as reliable? Because not everybody is Majid Sami, and we need 10 million neurosurgical procedures more in the world every year, right? So it cannot be that everybody is a genius, everybody is exceptional. We have to make it so that average people can do good work. I find that the ethical problems are around inconsistent surgical plans and around our lovely colleagues always saying yes. So, do you have this? Yes, professor, we have a microscope. Oh, we forgot there is no light bulb, but yes, we do. We have an endoscope. There's no irrigating sheet, but we have an endoscope. So then I go to the clinic and the pathology arrives, and here is an adult, has clear bad scoliosis, but no symptoms. The doctor, show us how you do it. Cut him like in America. Do it like Chris Shaffrey. But there's no indication to do it. I haven't followed them. I haven't seen longitudinal x-rays. Why operate? The middle one is a 16-year-old girl. She's not finished growing. Her parents are very tall. She's still very short. They haven't measured any Cobb angles in between. She has no pain, no deficits. I am hesitant. I am more hesitant to proceed when I'm abroad than in my home institution. This patient, I do quite a lot of syringomyelia. I have many techniques around it. This patient with the syrinx has minimal symptoms, has some numbness in the arms. If you do a myelotomy, you could make her worse. I don't have mapping. I don't have neuromonitoring. So my feeling is that we have to be more conservative and not heroic when we go abroad. This is a case of a 4-year-old girl. She fell from a roof in Alexandria, Egypt. And this is 4 months after.
2 minutes.
She has some feeling distally, but no movement. I am the master of syrinxes. I said, oh, okay, we can decompress this case and I can shunt this. I will do a syringo-subarachnoid shunt. I wasn't prepared for this case. So of course, I don't have the syringo-subarachnoid shunt. So you have to improvise. We use a myringotomy tube from the inner ear. We shunt her. She starts to move her legs better. Oh, the American doctor fixed it in the local newspapers. The cavity is smaller. Everybody is celebrating, but 2 months later, the little tube gets occluded. The expansion of the lesion has gone right back to square one. I'm not there to fix it. I'm just the kind of gimmicky surgeon who came from abroad, did something and left. It's a terrible feeling to not have that continuity of care. This case came to the clinic. I referred him to Germany, actually to INI, but I don't think his insurance would permit it. But it's a thalamic tumor. I have no tractography. The man is pretty intact. I would not jump and experiment on people in a country where I don't have familiar equipment. I love anterior skull-base tumors. I'm very comfortable doing them. But this is my endoscope. All we looked at during the entire case is a bath of blood, no irrigation, no sheet. So I say, bring your own dissectors, bring your own tools, bring your own scissors. You can leave them behind if you're generous, but don't rely on the local technology. And decide what is your responsibility, okay? This person came in the hospital in Alexandria with a penetrating trauma to the head. Of course, I will help them. I am there, okay? I will try to help them. But primarily, I didn't go there for that. I went to do the elective cases, to think about in clinic and to select. And that anterior skull-base tumors, I don't have the ENT support, the skull-base reconstruction to do such a case just anywhere. So my conclusion is, if you are traveling down the path, you meet a patient somewhere on this road, they're in your car, and you take the wrong turn, you cannot turn around and drop them off because you're not in your home, you're not in your hospital. So we have to practice global neurosurgery very responsibly. We have to say yes most of the times, but you have to know the limitations. And I have a lower threshold and stricter rules to do surgery abroad because I don't feel I can answer to the patient the same way as in my home institution. I think there is more responsibility, higher risk, and of course, we risk also the license of the sponsoring physician and the home institutions. When I get a temporary license in China or in Egypt or somewhere, there is a lot of legal implications for that. So I want us to be, in the spirit of Professor Sami, global neurosurgeons, but to be diligent and very respectful of not creating problems where we go. Thank you for listening.
Thank you very much, Dr. Koga. Our next speaker is going to be via video. It's Dr. Nimrod Junias. He's going to be presenting establishing a neurosurgery residency program in Nairobi, Kenya, a success story. Mwangombo. Take us away.
Yeah, thank you. He sends his regrets. There is no narration. It just slides. It's a video.
Kenya yetu hakuna matata. Jambo, jambo bwana, habari nzuri sana. Wageni mwakaribishwa Kenya yetu hakuna matata. Ngiti jambo, jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu hakuna matata. Jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu hakuna matata. Ngiti jambo, jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu hakuna matata. Ngiti jambo, jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu hakuna matata. Ngiti jambo, jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu hakuna matata. Kenya nchi nzuri, nchi ya maajabu, nchi ya kupendeza, hakuna matata. Kenya yetu hakuna matata, hakuna matata, hakuna matata. wageni mwakaribishwa Kenya yetu, hakuna matata. Jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Kenya nchi nzuri, nchi ya maajabu, nchi ya kupendeza, hakuna matata. Kenya yetu, hakuna matata. Hakuna matata. Hakuna matata. Hakuna matata. Hakuna matata. Kenya wote, hakuna matata. Hakuna matata. Hakuna matata. Kenya wote, hakuna matata. Hakuna matata. Hakuna matata. Hakuna matata. Hakuna matata. Hakuna matata. Kenya wote, hakuna matata. Jambo wote, hakuna matata. Hakuna matata. Jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti jambo bwana, habari gani? Nzuri sana. Wageni mwakaribishwa Kenya yetu, hakuna matata. Ngiti Jambo bwana, habari gani? Nzuri sana. Wageni wakaribishwa Kenya yetu, hakuna matata. Eti jambo bwana, habari gani? Nzuri sana. Wageni wakaribishwa Kenya yetu, hakuna matata. Kenya nchi nzuri, nchi ya maajabu, nchi ya kupendeza, hakuna matata. Kenya yetu, hakuna matata. Hakuna matata. Hakuna matata. Hakuna matata.
You have it. 2 minutes. I'm sure I'll finish.
Thank you.
This is it, really.